So my name's Cory. I'm a doctoral candidate from the University of Houston Clear Lake, and I help moderate the community conversations that we have here. Really, we try to keep these as kind of an open forum, just for mostly discussion. Sometimes we'll have structure, sometimes we deviate. Either way is okay. Really, this is just a place for us to come together, share some ideas, and just really connect. As part of this, I will try to keep an eye on the chat as well, just in case anybody has any questions, thoughts. We also generally encourage individuals to unmute themselves as well, just in case something comes to mind, but whatever you're comfortable with is good. So as I said, it's great to have you all here with us today. And Naftali, I'll turn it over to you.
Awesome. Hello, everyone. It's great to see you. I always love getting together with you all, and it's especially nice to see some of your faces who are been with CFHA for many years. We appreciate your presence. This is a great conversation, and I want it to be a conversation. So intentionally, no slides. Intentionally an open forum. On my screen, I have it on gallery view, so I can see everybody all at once. I definitely recommend that if you're able to do that. What I'm going to do is just do a little bit of quick level setting around the conversation, why we're having the conversation, some of the questions around it, and then I'll just spur the conversation by turning it over to a couple of what we call super participants in the conversation. Yes, Rebecca and Jean. Jean Rusty. Sorry, Jean. I just saw your name on the thing, and then I said it. And then it's going to be open for us to kind of discuss both on the chat and using audio. So here's my best attempt at level setting what was a very long thread on Gaggle, and a very fun thread to read. It went a lot of different directions, but I thought a good place to start was actually where it started. So Sandy wrote, and I'm just going to give you an excerpt of what he wrote. I want to propose a presentation that I can't deliver. Some other group or groups will have to bring our attention back to the evolving role of the physician or other PCPs in the primary care team. How about an example of how best to engage docs in integrated care for the unique roles they can bring beyond being identifiers of behavioral health problems, prescribers, and referral generators? Maybe there could be a presentation team led by and made up of PCPs or other docs describing the developmental pathways in one or many sites, such as primary care, specialty practices, or community settings. So what seemed like a fairly benign request or idea launched a discussion about the role of primary care providers within the organization. Lots of people had really great ideas, thoughts, and different directions to take that. I think what Sandy wrote that was particularly poignant to me was that last part of a sentence where he said, how about we talk about how to engage primary care providers in integrated care beyond being identifiers of behavioral health problems, prescribers, and referral generators? I think that's the part that really stuck with me when I heard him talk about that, because it's something I've thought a lot about, particularly with respect to the development of the modern care team, or the sort of the dream that we had, especially in the early 2000s, of building out the patient-centered medical home. What would the patient-centered medical home look like? What would the care team look like? And I think we had a vision for the primary care provider that would be a vision that would free them from the constraints of fee-for-service billing, free them from the constraints of being widget makers, on track to see patients every 7 or 8 minutes. We had a vision for what that would look like that hasn't been fully realized. That's something I've been sort of meditating on lately as I've interacted with my own physician colleagues. So it brings up a series of questions around the care team, around the role of the physician, particularly vis-a-vis integrated care, and then also about us as a community. So I'm just going to throw out some of these questions in no particular order that we can consider in part of this conversation, and then I'll turn it over to Rusty and Rebecca. So one of the questions is, well, what is the role of CFHA in mirroring the care team, right? So one of the concerns in the thread was we don't mirror the care team, right? We mirror mostly one part of the care team, right? And why is it that PCPs, MDs are less represented among CFHA membership? And does this mean that they care less about this area? Probably not, but or that they're aware less of this area? Or are there other things here at work that maybe Sandy's comment, I would argue, kind of gives us some idea around, yeah, we've limited their role in a certain way, right? Second question could be, well, what is the role of the primary care provider in the modern care team? What is that role, actually? Are they just identifiers of behavioral health problems, prescribers, and referral generators? Because if that's the case, I'm not sure we have much to offer. And even if that's the role, maybe CFHA's job is to kind of point to a different role, right? Maybe that's part of what we want to work on and say, that's not really great team-based care. And finally, what are potentially some specific barriers and opportunities to involving MDs? My wife is a physician, so I have a keen understanding of what a physician's life is like and what kind of investment physicians make in associations. So that often colors my understanding of what's possible with regard to engaging primary care providers in an association specifically. And then even more broadly, just engaging primary care providers in co-creating this future, this sort of more future, fully realized vision of what the modern care team should look like, and by extension, what their role in the modern care team should look like. Lastly, my last comment here that I will make in it is to take a moment to step on my soapbox and just to give us a tangible sense of where our thoughts could go down the road if we think about sort of taking a lead on co-creating a vision for the role of the primary care provider. So I mentioned before that in the early 2000s, this is when I'm first getting into my own career. It's really the genesis of the patient-centered medical home, right? And there was this real dream at that time that if we just started edging towards value in our work and away from fee-for-service and away from procedural payment for procedures and things like that, that this would free up the care team to work in unique ways where we wouldn't solely operate off of the office visit as the main intervention point for a patient. And that dream has not been fully realized because what we really did is we layered on top of the office visit-based fee-for-service system, we layered on top of that integrated care and other efforts to drive value, right? So we never replaced the underlying system, we just layered more on top of it. And what we did is we kept the primary care provider at the center of it so that they have more work to do. So even if there's more support, say in the form of a care manager or a behavioral health consultant, the reality is that the provider has more work to do. They have to make that referral because they're always the first point of contact at a medical visit, other than a medical assistant that's rooming the patient, right? And I've always had this vision of why is it that the primary care provider has to be the first person to see the patient? Or does the primary care provider need to see the patient at every office visit? Or is the office visit even the best way to intervene with this patient to begin with, right? Those are sort of the questions that the initial vision for the patient-centered medical home allowed us to dream about, but we really haven't fully realized a way to get there. And I think those constraints have a lot to do with how MDs then then and other primary care providers interface with this whole notion of integrated care, and thus by proxy, how they interface with an association like ours that has promoting that vision as its core mission. All right, so enough level setting. I've thrown a whole lot out there. I'm going to turn it first to Rebecca for some comments. Rebecca, what kind of came up for you, either in my sort of level setting thing, or in the your response to the thread that Sandy started?
Okay, so you talk about the vision, and I've had that same vision, but I feel like in trying to reach in family medicine, we are trained to integrate all that stuff. Every visit, we are using behavioral health, addressing behavioral health issues. We are looking at medical issues. We are looking at lab values. We are integrating that every time, and we are used to doing that. And it's, on the one hand, I think hard for providers who are really good at that and have good relationships with their patients, and the patients want that time with the provider that they know. But now a lot of those relationships with patients are broken apart, and I think we have to approach it like the physicians are hostages. We are hostages to making a living, to support our family. Even when we're independent, still, we are hostages to payment systems, reimbursement systems, Medicare models. When we signed up for that incentive payment to go to electronic records, that was, I compare that to the Chinese Cultural Revolution, where you take intellectuals and put them at tedious tasks, and what the wounds that happen to people. And so in approaching physicians to try to change the way that we look at the practice, because I think the only way out, escape from this, being held hostage by all these things, is some kind of rescue plan like this, where you can help us get to that vision, and patients will appreciate it and like it. And that's the best part of my day, is interacting with the patients. But even when you've helped somebody that they tell you you've saved their life, you still, okay, now I have to leave here and go document, finish up this documentation and spend, hours of my personal time to finish this transaction. So that's where I would say, I think you have to look to the hostage holders to free physicians to be able to participate in that kind of model. And that's the corporate agencies, our professional licensing agencies. I looked into how many self-knowledge assessment activities does the American Board of Family Medicine have on collaborative care, integrated collaborative care. None. There are none. They don't even have that listed as an area of interest for them to help us select among all the different activities that we can do to recertify ourselves. So that's not really yet. They are a member of, I think last year the AMA organized 8 different associations, this American Psychiatric Association, the OBGYNs, the surgeons, all these different, anybody that's closely associated with primary care, to work on a roadmap to how to integrate primary care. I don't know, was supposed to develop an online resources and helping people to get there. But, they don't have the hospital administrators are most of the employers of physicians now, and they don't have any licensing requirements. So I think you have to go, approach them in some way.
Thanks so much, Rebecca. There's so much in what you said, but one of the enduring sort of images there is that metaphor of hostage. I think that's really appropriate because that's my experience of my colleagues, how they feel trapped. I think it's that feeling of being trapped in a system. And that's sort of what I was trying to get at before, maybe clumsily, with that whole idea behind the PCMH, because it was billed as this is going to be great for you. And I don't know that it, on balance, it has. I mean, I think there's certainly some areas in patient care that's been really helpful. And I think on balance, I like EHRs better than I liked paper charts. But it all still came back onto the PCP in a burdensome way, a very tangible way that just I experience every week, but especially this week on the patient side, is I really felt bad. I had some toe pain this week, and I thought twice about like sending a MyChart message to my PCP, because I'm like, oh, geez, my PCP is going to have to like answer this message on top of all the other stuff, and they're not getting paid for this. No one's giving them extra time to work on their MyChart messages. And my PCP is awesome. We have a great relationship, and he answered, back really quickly, but it's that extra burden that's never been accounted for. Right. And that's influenced the development of our integrated care models, because if you look at PCBH, what we often call PCBH now, a lot of it was built around the idea of offloading as much work as possible, because we could not possibly ask PCPs to do any more. That's not really the ideal for team-based care. Right? The ideal is a collaboration between the two. But we have to work within what's possible. Rusty, turn the floor over to you. You've got the vantage point of both obviously being a physician, but also a long history with CFHA from the very beginnings. So I'm really excited to hear what you have to say.
Yeah, boy, I'm going to have to try and really control myself here, because I take issue with a fair number of things that have been said. I would just say that at the outset, if it's an important goal of CFHA to be involved in engaging more PCPs who work in uninitiated practice settings as a way of spreading the IBH word to the rest of the practicing world, then it's time to figure out how to do this. I think I sort of think of the phrase of nothing about us without us. And when I looked on the website and found that there were no MDs on the board of CFHA at all at the moment, unless I misconstrued everybody's initials after their name, I was stunned to see that. When I looked at the 9 years of past presidencies, and only 3 years of which were occupied by an MD, by a primary care physician, I was also stunned to sort of see that. I dug up I have 100 pounds of files electronically about my time on the board. And when I was on the board in 2014, one of the 6 years I was on the board, we had 6 physician members of the board out of about 16. And 1 or 2 of them might have been psychiatrists, so you can take that away. But I mean, there was at least an MD viewpoint there. So I think that if you're talking about trying to sort of attend to this, if you think this is important to engage more PCPs to change the rest of the world, when I was president in 2014 or 15, I wrote an editorial that said, we've done a great job. And I want people to understand, we have done a great job. Practice isn't that as terrible as it was 5 years ago. This is like reading about institutional racism today. If you read books about what it was like in the 40s, or the 50s, you realize we have actually made progress. Do we have work to do? Absolutely. But we don't do things as grossly racially as we did in the 40s and 50s. And I think that the practices in primary care have transformed. Not every practice. There are corporate hostages out there, no question about it. But there are lots of systems like Kaiser that gives physicians an hour during their session to answer their MyChart messages. So people are being paid to answer MyChart messages. People are being given time to answer MyChart messages. So I think it's not the right goal for CFHA to solve the primary care physicians' problems. That's not really your job. I think to overstate the purpose of the patient-centered medical home was to make practice better for the doctor. That is just not true in the history of the PCMH. The goal was to make care better for the patient. It was to provide after hours, 24-hour-a-day access to patients. It was to coordinate their care. It was to deliver more of the services in the patient-centered medical home that the patient before had to go shop around in the medical neighborhood and get. As Frank Degree is always quoted, I always quote him as saying, without integrated behavioral health, the patient-centered medical home fails. And it fails not because it offloads work by the primary care physician, but because 80% of our patients come in with a behavioral issue. And we were not answering the call. And I totally agree with Rebecca. We are good. We are trained to do this in family medicine. We have behavioral people in our residency from day one. We are trained to do this. But just like we learn cardiology, we need cardiologists. And so we need members of the healthcare team. I don't think we need to be reminded of that lesson. No primary care physician needs to be reminded, of them being part of the team. And I think Sandy's characterization is wrong. We're not just referral generators and identifiers of behavioral health. We are recipients of input about our patients from our specialist colleagues, meaning our BHPs. We integrate that input from them. So I think that the CFHA's mission is to improve behavioral health care for patients. They need all hands on deck to do that. They need their own BHP squads, and they need us. And I don't think you're going to get a correct, balanced view about this unless you have primary care physicians on the board, and unless periodically you have a president who's a primary care physician. I just don't think it's going to happen. I think some of these mischaracterizations, and again, I have to admit, I'm a Pollyanna. I'm in an academic medical center, but we are in competition with Sharp, Scripps, and Kaiser in town. It's not like we don't know their lives. It's not like our residents don't go to work there. We get feedback loops, so we're not in that much of an ivory tower. Primary care is sharing its experience nationally. And I think we are fully engaged in transformation, fully engaged in team-based care. Behavioral health isn't the only group of people in our PCMH. We have pharmacists, we have social workers, we have integrative medicine practitioners, we have care managers, we have all kinds of people. We have nutritionists, without integrated behavioral health, the PCMH fails because you have 80% of the patients with those problems. 80% of my patients, they also have nutrition problems, but they probably don't have an immediate need to see a nutritionist. So I would just sort of say that this should be central to the CFHA's mission. I think we've deviated a bit in that mission by not attending to the primary care physician presence in CFHA, as evidenced by who we put on the board, who we make president. And I'll have to say that I copied all of the interchanges, on the CFHA blog into a Word document. It's 15 pages long, of everybody's, comments. And I have to say, there's enough primary care physicians in that string, you could put them on the board tomorrow, and you would improve the, you would answer the nothing about us without us problem, pretty quickly. You'd have balanced discussions about what's true about primary care. I think there's a whole bunch of other specific solutions that I think maybe we'll get to, but I would also just want to say one other thing. Integrated behavioral health is still gathering force in the country. We just had a conversation 2 days ago, Bill Sieber and I, with the AAMC. The AAMC, not exactly a liberal organization in my experience. They have a behavioral health subunit, integrated behavioral health squad, that's publishing papers and giving training awards to promote integrated behavioral health in the academic medical centers that make up the AAMC. That's pretty significant evidence of having arrived. The AMA BHI collaborative that Jen Thomas mentioned is the AMA, for God's sakes. I mean, they're finally getting it. So I think that the idea of partnering with other organizations, in terms of ADFM, Society of General Internal Medicine, departments of family medicine, the AAMC, the AMA, this is where CFHA could connect its organizational reach to other organizations and help them out. We were flattered that the AAMC reached out to us. And the other organizations that I've mentioned over the years is Shared Care in Canada. I'm a giant fan of Shared Care and are getting together with them. And also I've made the recommendation, this is for more detailed work later, the Association of Medicine and Psychiatry, which has 85% physicians and 15% behavioralists. And they have the common mission that we have, at least in a lot of ways. So I think that those are things that we could do immediately that would make the conversation a little bit more reality balanced. And again, I think that the goal of CFHA is to improve the overall care of our patients. It's not to save primary care physicians. So that's what I'll say and kick off the discussion.
Love it, Rusty. Thank you. Thank you. Just a clarification before we go to Bill and then just open it up. I'm not going to belabor this, but we actually have had consistent medical presence. It hasn't been as much as the board has wanted. So the board has actively been seeking out MD, PCP board presence for several years. Jen Thomas, just so everybody knows, Jen Thomas is an MD and on our board, our newest board member. So just you should know, she's a great point of contact for our board. Bill, you're first, and then Laura after you.
Yeah,
I was just clapping. I was just clapping.
Okay. Bill, Laura's clapping. Okay.
clapping.
Clapping for you, Bill. Go ahead.
Well, just a quick follow up to Rusty. It'd be hard to. It's hard. He's a hard guy to follow on this, but we were on the board at the same time and looking at membership issues. And I can recall a day, Andy Valeris, who was a physician I worked with, who came in and said, I went to CFHA and I don't see anything there for me. And I said, well, talk to Rusty, and he became president, right? So for 2 years. So I think there are a lot of Andy Valerises out there. I think each one of us could probably find more to recruit it. And we were at the board in that time. I think Rusty was sort of a strong voice, but all of us were really looking for ways to connect organizationally, but as much personally too. Who is that person you work with all the time that has no idea or, would find some home here? I think it is not all of them, but I bet every one of us in the organization know one person that would be interested, a colleague that way. So I think there are ways to do it. I totally agree with Rusty's trying to continue to bang the drum to get more involvement there.
Thanks, Bill.
And I just have to correct myself. I do apologize to Jen Thomas. I misread that, I'm doing that at 2 a.m. I misread your initials and I stand corrected.
All good. No worries, Rusty.
Yeah. Point still stands. I mean, it's been something the board has had concern about, the idea that we want more representation at the highest levels of the organization. And frankly, I would love to have an MD, PCP staff member, and that's part of my vision going forward around building staff capacity, because I think that would help us build partnerships with a lot of these external partners, which we have had some, actually, as you've noted, Rusty, we've had some success in recent years. We've had that collaboration with AMA for several years now. That's huge. We've have had connections with other physician societies, STFM, APA. So but it would really, you know, you want to see people that, it's sort of like representation matters, right? You want to see people that look like you, that are like you, that've gone through the same experiences as you. That matters. And I think that's a big piece of this. Other thoughts, reactions to any of this, or what Rebecca or Rusty have posited thus far in CFHA's role in all this?
One thing I wanted to add was that in my speaking about rescuing the primary care provider, it is to make them available to the patients to improve patient care. Because, you know, we are answering those My Chart messages. We always have answered those kind of calls. We have called in things for people on the weekends to, you know, keep them from having to go to the ER, or now urgent cares, things like that, for people that we know, who we know will follow up. And we need to be fostering those kind of relationships. And there are ways to get paid for that kind of time. If a particular patient accumulates enough of those kind of contacts over the course of a month, and they have complex medical problems, you can bill for that time that you spent on those types of things. You just have to have a system of keeping track of it. So it's a matter of organizing ourselves and using the tools. I'm not against electronic records. I agree. They're much better than paper charts in many ways, as far as being able to see everything in many different systems and track that down, but it takes time still to do that. And in day-to-day interactions, there are still too many of those things that only the physician can do in the way that the chores are assigned or privileges given within office staff. So, you know, the roadmap that I would like to see is, you know, practical things. I see these things on your group email where people are asking questions, asking for tools, saying, I'm working on this. What do you know about this? That's the kind of you know, support that helps improve care to the patient.
Thanks. Jen?
Hi guys. Yeah, I'm Jen Thomas. I'm fairly new to CFHA. Like, I didn't even know y'all existed till like 2018, and I'm embarrassed to say that. I feel like I was living under a rock. Like, how did I not know about this organization? So yeah, I guess in the years I've joined, I've been so grateful for just mentorship, like the accessibility of your members, you know, like reached out to Naftali, cold emailed him, and he actually wrote me back, you know. And I personally was never really involved in my professional organizations. I love AAFP. I mean, I read their journal, but I was never involved. So joining a CFHA, just, I don't know, there's a spark of like, they really want their members to get a lot out of it, which I really felt from the beginning. And I think that's why I was like, sure, I'd love to join the board. You guys actually practice what you preach. You're engaging your membership. You're reaching out to them. All are welcome. And that felt really refreshing. So yeah, I just want to speak quick to the point on the AMA's BHI collaborative. So yeah, I feel like imposter syndrome, like right place, right time, that they're like, hey, do you want to be a clinical advisor? And I'm like, who am I? I work in a community setting. I'm not in an academia, you know, long resume, look out all the published. I don't do that. I just, you know, churn out primary care visits for the last 12 years since I graduated residency. But you know, my program, we got lucky. We were in the right place, right time, and got in the door with AIM Center, and we joined a collaborative care study in 2018 for perinatal depression. And then we joined CHAMP, which is weaving in opioid use disorder care with mental health using the collaborative care model. So I'm kind of an AIM Center trainee, but you know, I literally had not heard of PCBH. I didn't know what it was. I started listening to the podcast and hearing Naftali and Bridget and you know, people talking about this acronym. I had to Google it, and I was like, oh, like how I wish that's a, you know, like a missed opportunity. Like, I don't know how or where, but I'd love to be part of that conversation of getting the word out to the average Joe, the average PCP. A lot of communities in this country, it's a nurse practitioner or PA that's delivering that care, and, you know, having them know all about what BHI is. So that's why I think the AMA's Behavioral Health Collaborative is a good start. But I'll tell you, it's not the whole enchilada. We're teaching 24 providers. I mean, that's just, it's not even scratching the surface. So I'm excited to see where it goes from here. But they have the right people at the table, I think, you know, the family docs, pediatricians, ACOG, the AOA, and American Psychiatric Association. So I think there's an intention to work together. It's just, right, how do we support that and get the word out to folks like me that were like, hey, I think there is something to this, doing more in the primary care setting. I need help with this. I can't do it all. And I guess I'll just share my comment on my leadership perspective. At my organization, we were sort of a dinosaur in that we were base salary till right before COVID. We went to the RVU model. So I am one that is not directly affected by how much leadership time I spend is decreasing my RVUs, hence my compensation, but that's coming. That's kind of been held over my head recently of like, well, you're less productive. You make a lot less RVUs than you used to when you started here, because I'm our director of integrated behavioral health. And that's been a real push-pull of like, yeah, I mean, if you had a, blossoming mentee in IBH that's a physician, the quickest way to squash them is like, well, you're going to take a pay cut, or you're going to get pressure of your productivity is less, you're non-productive now. And that's the feedback I've gotten. I mean, I had an administrator tell me in November that me going to half and half clinical, half leadership was going to hurt the hospital. And I was like, oh my God, but look at all that we brought, right? We're doing integrated behavioral health. But, kind of speaking to some of your guys' points on that, feeling hostage, it's like in the real world, PCPs have to serve that eat what you kill mentality. So it's tough. I think there should be that move toward value. I'm not there. My health system is so not there. We are fee for service, hands down, up and down. So I'm not sure how to solve that, but I would love to be part of the conversation to move the needle, because it's needed. So I don't know if that's worth anything, but that's my 2 cents.
So much of what is done outside the encounter is what really is valuable to the patient. Disability forms and all this extra stuff that comes in, prior authorizations to get the medicine that you prescribed. It's just, and it takes a lot of that takes more and more of the physician's time just to be able to dodge the obstacles that payers put out there to be able to deny things. It takes a really intrepid person to complete some of those things in a successful way.
Again, I just want to, sort of say again what I said before about the fact that these are all, there's no doubt that all these things are true. They are a huge challenge to primary care. It's not like we're growing primary care doctors like the country needs. But I think that I would try and focus CFHA's efforts exactly on where the cost effectiveness is for treating patients who are depressed and diabetic, that cost twice as much as treating a patient who's just diabetic. That's the kind of angle that CFHA needs to make in terms of proving, Jen, that your job is worth something to the organization. I have no quarrel with, and I resonate deeply with all the cri de coeur that's going on about primary care, but I think CFHA has to understand what its mission is, what its job is. And I think if you stay true to improving the mental health care of the patient, which will be cheaper for the organizations you work for, that's the angle to sort of do this with, rather than to sort of provide aid and succor to my challenged brethren in primary care. I mean, when you collaborate with a team member, that takes time. You're not, if someone reaches for the Kleenex box and start to cry, and my answer is, this is going to take up, another 20 minutes of my time. Let me find the BHP to dump this on so I can go on and see the next patient. That's not a very noble way to live. And so I think your first thought might be, how can I help this patient? Can I help them with the behavioral health skills that I have as a family physician? Or is this going to take a little bit longer? Or do I need to get them connected to someone who will be able to spend more time with them to answer their problems? If you're doing better medicine, it always takes more time. When we initiated universal screening for behavioral health, for depression, because we had IBH for 8 years already, and the U.S. Preventive Services Task Force came out and said, you should universally screen for depression, but only if you have the means to take care of it if you uncover it. A chicken shit view in my perspective. But we sat around the table and said, well, we've got integrated behavioral health. We've got, we should be doing this. So we screened and we found 200 patients we didn't know about that had depression. significant depression. That's where we need to sort of collaborate, is to improve the behavioral health of our, of our patients, the overall health of our patients. And it is an interprofessional team activity.
Yeah, I agree, Rusty. And I think one of the cool parts about observing my clinician self now, as opposed to a few years ago, is it raises all boats. Like, yes, at first it took me more time to do more assessment of behavioral health, but having a LCSW in my clinic, literally next door to me, that's now a friend and colleague, and having that psych consultant, I've learned a ton, and I'm so much better at identifying and more quickly assessing and knowing, oh, it's not so clunky to know these meds. I've done them 2-3 times. Now I've done them 20 times, so it really does, it's culture change. I really do think for primary care docs, it has to be practice transformation of having the PCP want it and demand it. I mean, in my health system, it's like the PCP's got a whiff and they're like, ooh, what's this collaborative care thing? I want that. And I do think that we're not going backwards. I do feel like the PCPs demanding it. I mean, that has been how we've expanded. We have 10 sites now that do collaborative care. The PCPs are like, hey, this works. I want it too. And there's, I think, probably not a stronger, motivator to the administrators than saying, hey, your workforce, your docs are like, I got to have this, make it happen for me. So I'm hoping that momentum keeps going. Love to see that happen.
To Matt's, point in the chat, I don't think it has to be in opposition though. It doesn't have to be like PCP benefit versus patient benefit. And we see that in the literature, and we also see that in clinical practice. I think part of the problem is a lot of our clinicians are top down told you have to see more patients and do X, Y, and Z, which actually does not make sense with an integrated care model where we're also looking at what is the best ways to care for an overall population, which is not just churn and burn, seeing more patients. So we need to have better dialogue, I think, up and down. And I think we can, have a space similar to like PCBH and COCM. They don't have to be in opposition. We can actually have them work together towards, shared goals. I do think that we could really serve the benefit for helping our primary care providers, making it more sustainable to be a PCP, investing in a way also that you want to be a primary care physician. And at the same time, in doing so, provide better care for our patients. And that's where really, I think the wellness literature comes in. So I'm on the wellness committee for my health system, and there's 3 really good articles that I put in here with wellness-centered leadership, as well as systematic case review, systematic reviews about this. That's what they show, and it's a multifaceted approach that ultimately is best. So not just investing in one or another, but recognizing by doing both and kind of investing in these key areas, we can meet the quadruple aim. So just kind of want to validate, I think what Rebecca's sharing is definitely spot on. I think what Rusty's sharing is spot on. And I think they can work together as opposed to be we have to choose either we're investing in caring for the patient or we're investing in caring for the PCP.
Yeah, and great point, Laura. And I think I heard that in both Rebecca and Rusty's comments. I think a other piece that you slipped in there very expertly, but I will highlight is related to that sort of vision for the patient-centered medical home, which was originally related to this idea of morphing towards better population health, right? That was the groundwork that Rusty pointed to, right? That we were trying to do better at. Diabetes was one of the first examples with the diabetes collaboratives in the late 90s, right? That gave us this vision for how we could do care differently than just treating people at the point of care in an office visit. And I think, I think that we could support the PCP role vis-a-vis population health by untethering the only, not, the office visit, it's still always going to be important to some degree. And as Rebecca pointed out, the relationship between a patient and their doctor is always going to be there. But untethering the idea that the only role is related to that unit of care, which has that downstream impact of all of the sort of things that we consider pretty burdensome about the current system that some providers and some systems are caught in, whether it's RVUs or just other productivity expectations. And so I connect this whole idea of a population-based approach to care to untethering the physician from the office visit as the only means through which to use the expertise and skills of a physician who's really a highly qualified individual to be broadly thinking about how to improve the health of their panel and through their community, but are really limited to kind of producing health widgets within an office visit format. So I think we're underutilizing the breadth of our folks. And I think that connects with this idea of burnout, because I think and the burden that providers feel, because I think that having that freedom, I think, would breathe life back into so many folks who really care about community health, really care about using their skills, broadly speaking. And I mention that because from a very practical standpoint, I think that is a barrier of entry to CFHA, because most of our conversations on a TA level, when we're providing consultation support to clients, the first and ever-present barrier in conversing with a health system, or specifically with a CMO, for example, or their provider team, is always how beat down their providers are and how little time they have for this. We know it's important. We know behavioral health integration is a big deal, but you should know we've got very little time to put any bandwidth in this area. And that's always a first hurdle. And we've gotten very good at overcoming that hurdle on a one-on-one basis. But I think that's also a hurdle for membership in CFHA and engagement, right? Because folks collectively are feeling that first hurdle. Like, I've got a lot to do. I've got a lot on plate. I'm being asked to do things that take priority over engaging with this association, right? So I think I'm sort of highlighting that whole idea of, like, if we cast a vision that is a positive framed vision for the role of the PCP, I think that could go some ways to helping people get past that hurdle and engage with CFHA more effectively. So
Absolutely. And so like a role like Jen, I mean, that should be valued at the same level, if not more than that direct patient care. So how could, in casting that vision, how could we make the financial as well as clinical case for kind of what Jen's describing that she's trying to do in the system? And instead of it being like, you're costing us all this, how can we show that value in ways that people then want to invest in that? Because ultimately, healthcare systems have to invest in that vision if they're going to get the returns on investment. Just adding a bunch of providers in a clinic is not going to do that.
Right. And to Rusty's point before, the truth is, if you compare us to 15, 20 years ago, we've made tremendous progress in that area, because there are much more proximal conversations around just that kind of thing. Now, are we to the point where we've sort of solved these things? Obviously not, but at least we're having conversations. 15 years ago, these weren't even conversations that we're having, right? So.
Yeah, I think, go ahead.
I was just going to say there are things going on politically too. There's a bill, HR 5218, that is for giving grants to primary care practices to develop integrative collaborative care. It's been in a holding pattern in the committee since 2021, but the American Academy of Family Practice had spoken about that to the administrator of HRSA last year. So those are things that we could use with the people that need to be convinced, administrators, about the value of this, to be able to deliver better care in this way, by having those kinds of grants, that kind of funding that helps pay for the process of getting there. And then it becomes sustainable in the value that you get from it.
Yeah, I agree with all these things, and I just again, it's always hard when you're in a discussion and there's a giant bell curve of who's your organization, whether they get it or not, and when you're attending to the south end of that bell curve, where they're just, the administrators just have whips and RVUs, and that's it, and they're totally unenlightened. You know, CFHA is not going to fix that, you know, by itself. So I'm just trying to limit the vision and the aim and the goal, you know, that CFHA has. But I think that when you come against those people, Naftali, when you're talking about when you're talking to, you know, to a CFO or you know, or a chief medical officer in that kind of setting, that's that retarded. You know, the first person who talks to them about doing anything transformational is going to get, you know, they're going to die on the barbed wire. You know what I mean? So, you know, I mean, and so you just have to be careful about what you talk about, you know, and I think you can talk about CFHA and integrated behavioral health and team-based care in the light of the mental health challenges, which are headline news. Everybody and his grandmother now understands that this is a big problem. You know, Fetterman's hospitalized, for God's sakes. You know what I mean? This is the nastiness around this discussion is dissipating, and so I think it's timely for CFHA to make its move, you know, into healthcare more broadly. That 100 million people with all these retarded widget generating RVU focused bozos, you know, but I think you need to make it in a focused way around mental and behavioral health. And the nice thing about the behavioral health aspect is that it affects chronic disease, which is the major driver of expense in all primary care practices. So you've got a wide enough lane to deal with. I'm just saying that you need to, we need to stick to that knitting. And again, I really would, and again, I can't tell you how apologetic I am to Jen, because I remember being very impressed with your comments at the last CFHA meetings I've been at, and to the organization for saying you have no MD, you know, so you have one. All right, so you know that, and I really would, Naftali, I would go after the people on this chain who are primary care physicians and say, so, you know, you were jazzed up about this conversation, you want to be on the board, you know, and you know, but I think that that's the kind of focus I would be is on improving mental health. That will improve the patient's mental health, and it will also improve the doctor's mental health, because when our patients are in distress, we're in distress. When we can't help them, we feel bad. And so when I have a colleague who's a cardiologist who can help them, I have a colleague who's a behavioral health person who can help them, I feel better. I feel like I'm doing a better job with my patients. And so we will always have those receptors out there, and sometimes we need to realize that we have them. And that's the focus message that CFHA has to sort of present.
Yeah. Yeah. Has there been an effort to like go out on the, you know, offensive and like go to the AAFP meeting with this is a CFHA or BHI presentation, or go to AAP national meeting and talk about behavioral health integration? Because I know there's a bell curve, you know, and you're never going to convince some of those widget makers, but there's a lot more PCPs that this strikes a chord and they go, oh, this makes sense, that they're curious and they're just uninformed. You know, they don't know what they don't know. And I think it'd be a cool opportunity to get really savvy with, take it out to them. Like, hey, PCPs, we're going to get really savvy and putting this in your face. If you need to know about BHI, you need to practice this way. This is missing from everything you've ever done. And we got to change that and like make some, you know, champions, maybe.
There are more Jennifer Thomases out there. You're unique for sure, but there are more of us out there, you know.
There are, yeah.
Yep, that's how I found out about, you know, all the models was at a conference in Washington, D.C. It was a palliative care and hospice conference, but you know, it was presentation of the research, the data on this is what works, and it's so practical. And it's every community can build it around what they have and the resources that they have, and and fill in the gaps for things that they don't have.
Yeah,
I mean, it just makes sense. It's, you know, it's beautiful.
Yep. So maybe some like reverse integration of like, okay, now I got to go get more active in AAFP and say, hey, you need to know more about BHI and do more, you know, courses or articles or whatever that looks like, to just put that in the view of your general population looking at your journal. I mean, in residency, we all had to read the journal articles, right? Is that a way to like engage those new learners on? And I think they have done a COC.
Well, there are a good many articles in the family practice journals.
Okay.
But
Though,
again,
is it like, do people learn this? Like, I'm 12 years out. Are they learning? I think they are. Like Bridget and Dave do great work on a family medicine residency, but like, are they learning this nowadays? I hope so. In training, like BHI is part of its diabetes and its hypertension, and about integration. Like, I hope that's part of the churning out the newbies, right? I hope so. I don't know. Good. Rest of your, yes, you are. Okay, good. So that's great. That's good to know that that's happening. That's great. So
Increasingly so, Jen. I think things have changed radically in the last 5 years, including our organizational capacity for even doing. So now you all have. I'm very tactical, so I'm in my brain. I'm like, yep, okay, we got to move on that. We got to move on that. We have capacity really for the first time as an organization to really think about that, based on pre-work we've done in building relationships, right? Is that we didn't want to just sort of cold show up at an AAFP conference and just like do a session, right? But we now have some built relationships. So with AMA, with Chris Botts and the BHI stuff and what came before the BHI stuff, that's a relationship that we have that we can start leveraging. And then going to an AMA conference makes a lot more sense. With AAFP, Julie on our team is working with them on developing they're doing their own sort of behavioral health integration type modules online. I don't know why they're doing it separate from AMA, but everybody likes to do their own thing. So she's helping lead a couple of their modules for that. So that's a relationship with AAFP. With STFM, we're building out a cohort group of behavioral medicine professionals across both groups, so that it's just an overlapping group between the two organizations. And we want to build relationships there so that, we can obviously influence things there as well. So I think we're starting to have capacity to actually get tactical about a lot of these things.
Let me just make two suggestions along that line, just under that heading.
Yep.
So the AAMC, I gave those people, I can forward their names to you, and I think you should reach right out to them. I gave them CFHA.net and said, go educate yourselves. We exist. There's a big force here that's been around for 25 years. You're just dipping your toe in this from the AAMC perspective. Go talk to the experts. So, you should reach back out to them and tell them, I gave their names to you. The second one I mentioned again is AMP, the Association of Medicine and Psychiatry. When I was president, I had conversations with their president, and to try and sort of do some sort of connecting there. And they're the home of the combined primary care psychiatry squads.
yes,
There's only 10 or 12 of those residencies in the country, but our program folded this past year, I'm sorry to say, after I stopped being chief of our division, but not that I could have prevented it. But they were around for 26 years, so they produced 50 of those people. 2 a year, and so I think that they are a kindred organization. They have a little bit of a different look because they sort of focus more, I think, on inpatient and liaison kind of work and stuff like that, and maybe more seriously mentally ill people. But and then the other thing I would Nick Cates just published his Canadian view of collaborative care, Canadian style, and I read it, and it's absolutely ditto everything we believe in. And Nick Cates is wonderful, and we had a joint conference, which unfortunately I didn't go to because I think it was the pandemic, and I felt really terrible about it because I lobbied for that for about 8 years. And I think we should look back to then, because I think binational organizations are a great way to fuel, it's a bigger group of committed people. Canada always has lessons to teach us about healthcare. And anyway, so I just mentioned those two angles. So
awesome. Well, I know it's the top of the hour. I just want to thank you all for taking time to share your passion and your thoughts about this. And I want you to know that they've been heard. I'm looking down because I wrote these things down on my desk here. I think there's some really actionable things here to kind of make some headway around this, but hold us accountable. Like if we feel like we're not making progress, like I don't know if you reach out to me, reach out to us as staff, put it on the listserv, whatever it is. I love this passion, and thank you to Rebecca and Rusty, especially for just bringing some really unique perspective to the conversation. I think really helped us get to a really nice place here. So thank you. And I would say to be continued.
Thank you all.
Thank you, everyone.
Thanks, Neftali, for organizing this. This was great.